Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
Welcome to this second episode of Polyp Gossip, where we deep dive into latest trends, topics and controversies in the field of rhinology and more specifically CRS with nasal polyps, also called nasal polyp syndrome. I'm Dr. Peter Hellings. I work as an ENT surgeon at the Catholic University Hospitals in Leuven, Belgium, and I'm very pleased to be co-chaired or to have a co-host, Professor Dr. Witske Fokkens from University Hospitals in Amsterdam, the Netherlands. This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with Euphoria. As the topic of today's Polyp Gossip is around smell dysfunction, we invited one of the world-renowned leaders in the field of smell loss and smell diagnosis, which is Professor Dr. Joachim Moyol, Director of the Rhinology and Smell Clinic at the University Hospitals in Barcelona, Spain. And together with him and Professor Witske Fokkens, we will gossip around all the topics that are relevant in relation to smell loss from a physician as well as from a patient perspective. And get ready for a lively discussion that's sure to bring fresh perspectives for both ENTs as well as for patients. If we then start the gossip and ask you, Joachim, about the prevalence of smell loss in patients with CRS with nasal polyps, what is in your patient population in Barcelona the prevalence of smell loss in patients suffering from nasal polyp syndrome?
Well, this is a very interesting question because the prevalence and the severity of loss of smell in CRS patients, mainly with nasal polyps, mainly differ depending on the evolution and the severity of these patients. Since we are in a tertiary hospital and we usually see the most complicated and comorbid patients, it's very, very, very rare to have a chronic rhinosinusitis with nasal polyp patients without any kind of loss of smell. I mean, I would say 95%, 96, 97%. But this is because it's a very specific kind of patients that we see in our hospital.
Would that be the same, Witske, in your institute in the Netherlands?
Yes, I think so, Peter. I think it's exactly the same as Joachim says. Far over 90% of our patients have smell loss. If you have a patient that says, "Oh, I can smell normally," the first thing I think is the diagnosis is wrong.
Smell loss has, of course, many different reasons and causes, and nasal polyp syndrome is just one of those reasons. So how can a physician or a patient recognize smell loss in relation to sinus disease? Could you give an idea on that? Joachim, you first.
Yeah, well, actually, the diagnosis of loss of smell should be directed to the loss of smell itself, but also in the context of a diagnostic of disease. I mean, sometimes, mainly in the COVID time, you may have some kind of overlapping loss of smell, but not especially in these patients. And the main issue that I would say that the difference between a viral loss of smell that is usually very sudden in relationship to an infection, a viral infection, in chronic rhinosinusitis, loss of smell is persistent and sometimes it's growing with the severity of age. It's not something that appears an anosmia, total loss of smell in a specific. No, it's starting with some hyposmia, patient refers loss, more loss, and finally total loss of smell in some severe patients.
Witske, what do you tell to a patient that has had a little accident and all of a sudden the smell is gone? Do you think of nasal polyps or do you think of other conditions?
No, as we know, the smell nerves that go from the nose into the brain are very fragile and are almost fixed to the bone. it's like a sieve where through the skull base. And if you have a car accident, for example, and you really bump your head and sort of move the brain moves up and down, then the nerves, olfactory nerves, the smell nerves can ripped, and you stop smelling. And very often that is forever. Sometimes people are lucky and it comes back partially, but not always. Like in viral infections, quite often it comes back, luckily. And for example, in COVID, in most patients, the smell came back, but not always. What I think is the big difference between these diseases and what you see in chronic rhinosinusitis is that patients keep having also other symptoms. So patients have nasal blockage, rhinorrhea, sometimes facial pain and pressure. So if you have a cold, for example, and you lose your smell, the cold goes away. You don't have the symptoms of rhinorrhea and nasal blockage anymore, just the loss of smell. And then you hope it comes back. But in chronic rhinosinusitis or nasal polyp syndrome, you see that all the other symptoms are there also all the time. And that makes it so debilitating and so frustrating and so tiring that these patients have symptoms all the time, not only of smell, but also of bad sleep, etc., because of their other symptoms.
I would like, if I may, add something that is very interesting, because sometimes, that is not very often, but sometimes you have patients with chronic rhinosinusitis with total anosmia that is not recovered. And in these cases, you also have to have in mind that this loss of smell, mainly when it's total, could be due to other causes, to an addition of a viral infection or to a previous accident. I have had cases of that the people actually lost the sense of smell much before having the nasal problem, and then didn't tell me at the beginning, and I realized that was due to the trauma, to the brain trauma.
So what do you do then, Kim, if you want to differentiate? You have a total loss of smell, total anosmia, and patient is not sure whether that is caused earlier or is part of the disease. So what do you use as a diagnostic tool to find out?
Well, the best diagnostic tool and cheapest that we have at the beginning is a short course of oral steroids to know if they respond or not respond. If a patients don't respond to a short course of oral steroids, either it's very severe, it is very severe, or the cause could be a different one from the chronic rhinosinusitis.
And why is that?
Yeah.
Why do
you never know, because even I have patients that have lost the sense of smell, and I know really that this is due to the loss of smell, and because of the evolution and the severity, mainly in patients with aspirin intolerance, that is, they are very severe, they don't recover the sense of smell. Even in the cases of biologics, or giving biologics, or giving oral corticosteroids.
But of course, corticosteroids stop the inflammation.
Of course,
so
of course.
That is why it works so well. And
yes. Well, this is very important, because loss of smell is more linked to the concept of inflammation of the mucosa than, at least in chronic rhinosinusitis, that to the concept of nasal obstruction. Usually, size of nasal polyps is not a very prominent issue, although in some cases when there is a total blockage, it may be, but in general, it's not the main cause. The main cause is the underlying inflammation, mainly type 2 inflammation.
Can I ask you, Joachim, it's funny that you talk about the treatment in the context of diagnosis. You mention steroid tablets for diagnosis of a problem that is or is not reversible or irreversible. So what about smell testing? And why you don't talk about smell testing before you would go into oral steroid treatments? And this is a bit of a gossip, so we can say whatever is reflecting the current reality, because we know that there is a significant neglect of smell testing in clinical practice, and we are just here to discuss those issues. So please go ahead.
Yeah, diagnosis of loss of smell is very important, but sometimes you don't need a whole smell test performance. One of the main issues that the smell test has is that it's time consuming. It's if you want to do a subjective olfactometry, that takes you 30 or 40 minutes if you want to do it well. Sometimes with a VAS that we usually use in our daily clinical practice is enough and gives you a kind of good approach to the loss of smell. For example, in our clinic, we perform this VAS score in all visits, and it's very good.
Yeah.
It's very good because at the same time we measure severity and we measure loss of smell, and it's very clear. Only in cases with strange situations of loss of smell, sometimes associated to dysosmia or to phantosmia or so on, we use loss of olfactory test, but not in all the cases.
Isn't it strange for a patient that if a patient has a vision loss, he goes to an ophthalmologist, and this ophthalmologist spends half an hour on testing the reasons why and the amount of vision loss. If a patient is having hearing loss and he goes to an ENT doctor, they do several audiology tests in order to test the hearing, and test the compliance of the tympanic membrane, and do lots of tests. And for the testing of smell or for the diagnosis of smell, this is not always taken seriously. So why is that?
Well, I understand that ENTs and allergologists are more used to work with more clear symptoms. We have hundreds of books talking about nasal obstruction or even facial pain, or correlating, although it's not true, pain or cephalea with sinusitis and so on. But the loss of smell has been a forgotten sense for many years, very unknown. And the patients, actually, I always say that neurologists, the first thing they don't do is to look for the first cranial nerve, and because they also don't look for the olfaction. Now it's improving very much because of the association with Parkinson's disease and Alzheimer's disease. But this has been a very forgotten sense, and now we are trying from different organizations, not only now, from many years ago, to improve that. I think most of our doctors are aware or start to be aware of the importance of assessing the loss of smell.
Do you agree on the point of view of Joachim Witzke?
Well, mostly yes, but we do smell testing in every patient, and I fully appreciate that it's easier in big university clinics than somewhere in secondary care, and that it takes time. But on the other hand, it's just what you said. There's no ENT surgeon in secondary care who says, I never do audiometry because I don't think it's relevant. And especially, for example, if we operate on patients, we really want to know how the smell was before the surgery. Because you don't want to end up with the patient saying, I lost my smell because of the surgery, for example. Yeah. So I think we really do not do enough olfactory testing, and that we should do more and emphasize the importance to our colleagues. And no otologist would ever operate on an ear without more than 24-hour old audiometry. And we operate on patients and never even did the smell test.
Yeah,
so
true.
Should be improved in my view.
Yeah.
Well, we all know that there is indeed the need for improvement of the smell testing and implementation of smell testing in routine practice. But imagine we do the smell tests in all our patients. To what extent will that have an impact on our approach? What do you think if we would do the smell testing on every patient, Joachim?
In every patient and every visit?
No. At least if a patient complains of smell loss, it's always good to have an objective or semi-objective way of how this smell loss is perceived and whether or not this can be objectivated and also be a parameter of follow-up of the disease, which I consider to be very important.
I totally agree, and I totally agree with Witzke that all these patients should have at least one measurement of the loss of smell. The patient should decide which one. There are shorter, there are larger, there are quantitative, etc. But the sense of smell should be assessed in these patients, at least at the beginning, or from the beginning, or before a surgery, or in the follow-up from several years, or from some specific treatment, or so on. But it should be done, and should be more often that is actually being done.
I'm actually very curious about a practice in your institute in Amsterdam or in Barcelona about a combination of smell tests also with taste testing, which we often combine because many patients with smell loss also complain of loss of taste. And in our center, we always combine the two tests, and we are privileged enough to have it in the tertiary care center, which is quite often not the case in non-academic centers, but it's not so complicated, it's not so expensive, and it's not very time consuming. What's your idea about it? Witzke first and then Joachim.
We only do taste testing when there are specific symptoms that we do not understand. For example, when patients say they taste strange tastes, not just less, but strange, or if they cannot taste the primary things you can taste, salt, bitter, sweet, etc. We do not do regular everyday. We do regular everyday smell testing, but not regular everyday taste testing. Only on indication, I must say.
Mm-hmm. And Joachim?
I think that we have to make a point in this specific issue, because sometimes there is a lot of confusion about the meaning of taste. In English, taste sometimes can be considered, or it's considered by many people, as a concept of flavor, of the sense that you have when you eat or you drink something. But this actually is flavor. It's a common sensation that we have due to the olfaction and due to the taste. But real taste, what we call real taste, is only something linked to 5 perceptions, the main of them: salted, sweet, bitter, and umami, and acidic. We perform the gustometry, this specific gustometry, in all the patients that we perform olfactometry. Sometimes to show to the patients that the real problem is the olfaction and not the taste itself. 95% of the patients that I receive for an olfactory dysfunction also are referred because of a taste dysfunction. And most of these patients, the majority, the 90% of these patients, they don't have any taste problem. They have a flavor problem. They cannot recognize the food, or they cannot recognize what they are drinking. But the taste, the sensation, the perception of salted or sweet, it's perfect. And that test that is quite easy to perform, we perform it always with the smell test.
Well, 30 years ago, when I was trained in ENT, our professor told us that losing your taste is losing your smell. Your sense of smell is worse than losing your taste. Would you agree with that, Joachim, now that we have better insights and we know more about nasal polyp syndrome? So can you share your opinion and tell whether or not this professor was right or wrong?
Well, that depends on if you lose the taste only, for you the worst will be to lose the taste. That it's what is affecting it's what affecting you. But it's much less frequent to lose the taste, the real taste, I mean, that the sense of smell. And I think for people is more a problem with the olfaction. You have a number of perceptions, a variety of perception of relationship with your environment, with the people who is close to you, family, with the things that you are located, and both are important. And it's difficult for me to say that which of those senses are more important. But since the problem is more frequent for olfaction than for taste, I would say olfaction.
Okay, then at least you agree to some extent. Witzke, if you see a patient with smell loss in Amsterdam, a smell loss in the context of nasal polyp syndrome, how would you approach that problem? I mean, from a therapeutic perspective, what would you inform a patient about? What treatment options would you offer a patient? And let's imagine a patient with the first presentation of CRSwNP, so nasal polyp syndrome, without having had any surgery before. And then the next question will be to Joachim, in a patient with a similar problem who has had surgery performed, but still complaining of smell loss. So Witzke first.
Well, we start with discussing with the patient the cause of the smell loss, explaining that it is an inflammatory issue, that it's not blockage per se, and automatically linked to that is that opening up the nose is not usually not working for a long time. Sometimes improves the smell shortly, but very often the symptoms come back. So that's the first thing we discuss with patients, that we are going to do surgery, usually, why we are going to do surgery, explain that we do surgery to open the sinuses, to have access for nasal corticosteroids as an anti-inflammatory treatment. And very often, if smell loss is the real main reason to see the patient, and that's the complaint the patient is most involved with, we start with a short course of systemic corticosteroids, as Kim already said, to be sure that actually the inflammation is the reason of the smell loss, and that it will come back if we do an anti-inflammatory treatment. So first diagnose, but I think that's really still diagnosis. We use a systemic corticosteroid as a diagnosis to know whether the patient is able to smell. Then we do the whole discussion that it's an inflammatory problem, not a blockage problem. Then we do the surgery, explain to the patient why we do surgery, to get the anti-inflammatory treatment at the place where the patient smells. And then after the surgery, we keep telling how important it is to use anti-inflammatory treatment, and if needed, use either systemic corticosteroids again or move to a biologic, for example.
Witzke, I know you don't perform large numbers of primary sinus surgeries because you work in a center where you collect the most severe cases from the whole of the Netherlands. But what would be your estimation of likelihood of success of surgery at the level of smell impairment? In what percentage of patients do you think smell loss will be reversed by primary sinus surgery, looking at, for instance, 3 years after surgery? How many of patients undergoing sinus surgery will maintain or have a good capacity of smell at 3 years after surgery? Make a wild guess, because we can only guess, of course, but make a wild guess.
We don't have the data, so it's very difficult to say. And then, of course, very important is, do you only look at patients with type 2 polyps, or the whole syndrome of chronic rhinosinusitis?
Yeah.
So if you say all chronic rhinosinusitis patients, is probably relatively okay, if you talk about patients with type 2 inflammation and polyps, it would be a wild guess, but my guess would be 50% after 3 years max.
Okay, and then this patient is going to Joachim. He's moving to Barcelona after a previous surgery, still having smell loss, and seeing Joachim for further advice. So what do you then advocate for in the context of persistent smell loss in those who have had surgery before?
Well, the approach to that is quite complicated. In general, our approach is very similar to what Wisk has said. We, in general, never indicate surgery because of the loss of smell only. Sometimes patients go to the doctor and say, I have lost the sense of smell. I don't want to do any treatment, but I want to go under surgery. I mean, one of the main problems, not only because of the loss of smell, but also because of severity of the disease, is that patients don't follow their appropriate medical treatment. And when I'm talking about medical treatment, I'm talking about silent lavages or and intranasal corticosteroids are higher doses, what the doses that should be given. I think it's important. If a patient that is well treated with appropriate treatment receives an indication of surgery, and the surgery is well performed, and the patients don't recover at all the sense of smell, that could happen sometimes. That could happen in very severe patients, and mainly if they have received not 1 or 2 or 3 previous surgeries. But also we have to do a differential diagnosis with other causes of the loss of smell, and try again a potential short course of oral steroid to see inflammation could be the main cause or not. I mean, that should be done case to case, because you can have a variety of patients that could respond in a different way. But if you are sure that this loss of smell is due to chronic rhinosinusitis, you have performed the surgery, the patient is being treated well, the impact on quality of life is lost, and so on, I think that the next step would be potentially a biologic. That could be one potential indication of using a biologic, or at least helping taking the decision, as is present in euphoria and EPOS criteria.
Yeah, and to what extent has this availability of biologics changed the therapeutic landscape and also led to a higher likelihood of patients getting their smell back? Maybe Joachim first, you have experience now with all the trials and all the real-world efficacy efforts that have been undertaken in several countries in Europe, where we know that the likelihood of smell coming back to normal is substantial. So to what extent this availability of biologics has revolutionized care for nasal polyp syndromes? Can you give your idea about what's happening in Spain, and maybe Witzke then what's happening in the Netherlands? So Joachim first.
Well, I can give you the what we know from the clinical trials. We don't have a specific experience in Spain because, as you know, until recently, until 1 year ago, we don't have had the reimbursement for treating patients with biologics. But what the study says, that is, from the patients that usually are included in clinical trials for biologics, 80 to 85% of them are anosmic, and 95 have some kind of loss of smell. And this anosmia is recovered more faster or less faster, or with higher impact or less impact, depending on the biologics. We have to understand that not all biologics also have the same potency in improving the loss of smell, and that has been shown in the clinical trials. Some, they have mainly the anti-IL-4, they have a very strong effect on the loss of smell. They are able to reduce anosmia in 1 year from 80% to 15%, and probably in real world studies much more, as probably Witzke will tell us, because the patients are better selected. But still, there are patients that don't respond, and we don't have a clear explanation for these 4 or 5% of the patients that then they don't respond very well to biologic treatment, at least concerning the loss of smell or the anosmia even.
Yeah, I'm very curious to hear now the real-world experience of Witzke in context of smell and smell loss getting better after the novel treatment options we have since a couple of years. So Witzke, you did a lot of efforts in that research field, so please share the data you generated.
Well, we now have about 500 patients in real life on a biologic, mostly anti-IL-4. And I really had to realize after, we were so enthusiastic when we started this in 2019 and then said to patients, oh, you will have your smell back in a week. Because in quite a lot of patients that actually happened within a month. When they first see us again, they objectively had their smell back. We do smell testing again after a month. But sometimes it takes a little longer. We don't know exactly why that is different between patients. So we really had to stop ourselves saying, because patients came back after a month and said, I don't know, maybe I'm a lost case because I still can't smell. So that was our first experience. Now we know that that patients who react favorably to a short course of systemic corticosteroids, so we looked that up or asked the patient, when was the last time you had a course of systemic steroids? Usually they had it in the year before. If they say, oh yes, if I have had my prednisolone, I can smell, then I now promise them that biologic will bring the smell back. If they say no, the chances are much lower. So there is, of course, a small group of patients that are totally anosmic, either because of the severity of the disease or because of all the surgery we did in the past, and who will not get their smell back because they are anosmic and it cannot be repaired. But that's a very small minority. Most patients get their smell back. Not all patients become perfectly normal again with their smell. Some have still a little bit of hyposmia, but in general, it's in that sense a fantastic development for our patients. And especially in the past, I had a lot of patients who we just gave a very low dose of systemic corticosteroids to keep them smelling. Certainly patients that needed their smell for their occupation, for example, or for other reasons where it was very important that they could smell. We kept them on low-dose systemic corticosteroids with all the consequences, long-term consequences for comorbidities, other diseases that develop if you do that treatment, but it was a choice between two bad things. Now we don't have to make that choice anymore. Now we can just go for a biologic and help patients in that way. And that's a fantastic development, I think.
That's indeed a fantastic end of this show. And maybe Joachim also wants to add something to this fantastic statement of Witzke.
In the international guidelines, loss of smell or significant loss of smell is used for the indication of biologics. I would say something else, that loss of smell could also determine which of these biologics we should use or we can use, because they have much more potency in loss of smell in patients with anosmia. And that is actually what we use, that as not only because of the indication, but also by the kind of mechanism that is used for this biologic to decide which of them will be given in a patient which the main symptom, the main problem, the main situations is the loss of smell.
Before we end this show or this episode, nasal polyp gossip on smell loss and all the associated considerations in relation to diagnosis and the treatment, Witzke mentioned fantastic news for the patients, but how do you feel, Witzke, as a surgeon, being able to treat your patients not only with surgery but also with another non-surgical option? Do you also think that is a fantastic development, and how do you feel nowadays about being able to treat patients with smell loss in the context of nasal polyp syndrome?
Well, it's humiliating and maybe sometimes very frustrating that something we couldn't achieve as surgeons is now done with a simple shot once every few weeks. So as a surgeon, that's frustrating. On the other hand, of course, for my patients, I'm so happy that we can now offer them something that we were just not able to offer them with surgery. But having said that, of course, a significant, we said that at the beginning, a lot of patients are well treated with surgery and nasal corticosteroids and do not need a biologic. It's the group that end up in tertiary care in the clinics we work in, who often have had a number of surgeries already in the past and a lot of systemic corticosteroids and still no smell and severe impact on their quality of life and very often have asthma. That are the patients that we suffered with, that were the nails on our coffin, and that now we have these fantastic new options. But there will still be a lot of patients that are very well off with the things we did in the past. So we shouldn't discard all the things we did before because we have something new.
Wonderful. I think this is a nice wrap-up and a euphoric statement to end this Polyp Gossip episode with. So we have more and better treatment options. We have better tools to diagnose smell dysfunction. And I think the next episode will definitely be appreciated because it will all be about talking with the patients. We have been talking about the patients today and how impactful smell loss can be. And the next episodes of Polyp Gossip will all be about talking with the patients, with sharing their frustrations and hearing how well or how frustrated they are in relation to the diagnosis and treatment of nasal polyp syndrome. I would not like to leave you without thanking our guest of honor of today, Professor Joachim Muyol from Barcelona, and also our co-host, our wonderful co-host, Professor Dr. Witzke Fokkens from the Academic Medical Center in Amsterdam, the Netherlands. So thank you so much also to all the listeners and viewers for having been with us during this second episode of Polyp Gossip, and I warmly welcome you to the next episode, which will be released shortly. Thank you very much and see you soon.
Polyp Gossip. This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with Euphoria.